Welcome back to the deep dive. We're shifting gears a bit today. Usually we take this big, broad look at a topic, but today we're going to narrow our focus.
We're putting on the white coats.
Exactly. We're walking onto the wards. Welcome to a special edition, Pharmacology Grand Rounds.
That's right. And I want to give a special welcome to any second-year medical students who might be listening in. I know you're right on that cusp of starting your third-year clerkships.
Stepping out of the classroom and into the real world.
Into the hospital, yeah. So treating this like a grand rounds session just feels right, because we're going to do exactly what you'll be doing in just a few months, taking all that clinical science and applying it to a real person.
So we're not just, reciting drug names from a textbook today. We're looking at a specific case, a patient of yours, I believe, to really understand how to manage a condition that is, well, it's incredibly common, but so tricky to get right.
It is. I'm talking about chronic insomnia in an older adult.
Right.
I want to introduce everyone to a patient I've been seeing. We'll call her Amy. And Amy's case is this classic high-stakes puzzle. She's desperate for sleep. She's really suffering. But the go-to medications that doctors might have reached for, say, 10 or 20 years ago, we now know they're actually dangerous for someone her age.
It's that ultimate clinical balancing act, isn't it? You have to relieve the suffering, but you can't cause more harm in the process.
That is the job, in a nutshell.
So let's start at the beginning, the patient profile. Who is Amy?
So Amy B. is a 66-year-old retired school teacher. She came into my clinic a few months back, and her chief complaint was simple, but, really heavy. She just said, "I cannot sleep."
And this wasn't just a bad week.
No, no. When we dug into the history, this has been going on for 6, maybe 7 years, and it's been getting progressively worse.
And for the students listening, we know that I can't sleep is a starting point, but we need the specifics. We need the metrics, the sleep log.
Precisely. In sleep medicine, the log is your best friend. So we had Amy track everything for 2 weeks, and here's the data. She gets into bed at 10:30 p.m., but then she just lies there.
So her sleep onset latency is high.
Very high. It's consistently between 1 and 2 hours just to fall asleep.
And anything over 30 minutes is considered clinical, right? So 2
That's
hours
right.
is severe.
It's severe. And then once she's finally asleep, the battle's not over. She has poor sleep maintenance, wakes up multiple times a night, and then she has what we call early morning awakening.
Wakes up and can't get back to sleep.
Exactly. Wide awake at 4:30 in the morning, even though her alarm isn't set until 7:0, just staring at the ceiling.
So if you do the math on that,
Hmm.
her total sleep time is what? 4, maybe 5 hours a night?
That's it. It's a brutal way to live. And to make the official diagnosis of insomnia disorder, we have to see that it's causing daytime dysfunction.
Is it affecting her life?
Oh, a resounding yes. She's fatigued, she's irritable, her concentration is shot. She used to be really social, active in her community. Now she just doesn't have the energy. She's pulling back.
That paints a very clear picture. Now, before we jump to the prescription pad, we need to understand the architecture of her insomnia. There's a great framework for this, the 3P model.
Yes, this is essential. If you're a student, you've got to write this down. Predisposing, precipitating, and perpetuating. It's the key to taking a good history for insomnia.
Okay, let's break those down for Amy. First, predisposing factors. What makes her vulnerable?
Right. So she's female, she's 66. We know insomnia is more common with age and in women. She also describes herself as having anxious traits, a bit of a worrier. That's her baseline vulnerability.
Okay, and the second P, precipitating,
Yeah.
the trigger.
Mm.
What kicked this all off?
For Amy, her husband passed away about 8 years ago. Her sleep problems started about a year after that. The grief, the loneliness, that was the event that first broke her sleep rhythm.
But that was years ago, so why is she still not sleeping? That must be the third P, perpetuating.
This is the key to why it becomes chronic. Perpetuating factors are the things the patient does to cope that paradoxically make it worse. So for Amy, she's napping in the afternoon because she's exhausted.
Which feels logical, but she's just stealing her own sleep drive from the night.
Exactly. She's snacking on sleep during the day so she isn't hungry for it at night. She's also a clock watcher. Stares at the alarm at 2 a.m., gets frustrated, spikes cortisol.
And cortisol is a wake-up signal. Vicious cycle.
It is. And we have to talk about substances. She has a glass of wine in the evening, her nightcap.
The nightcap. So many people think that helps.
It's a classic mistake. Alcohol is a sedative. Sure, it might make you lose consciousness faster, but it absolutely destroys sleep architecture. As it metabolizes, it causes this rebound arousal in the second half of the night. That wine is very likely why she's waking up at 4:30 a.m.
Okay, so we have a diagnosis, we have the 3 Ps. What has she tried so far?
So she has tried cognitive behavioral therapy for insomnia, or CBTI.
And just to be clear for everyone, CBTI is the gold standard. It's first-line treatment.
Absolutely. And Amy gave it a solid effort for several months. She got a little better, her sleep hygiene improved, but it just wasn't enough. She's still suffering, so we have to consider adding a medication.
And this is where it gets really tricky for a 66-year-old.
Very tricky. Before we decide what to start, we have to see what she's already taking, because like a lot of desperate patients, she's been trying things on her own.
Right, this is the safety check part of the visit. So what's she taking now?
She's taking zolpidem, that's Ambien intermittently, and she's also taking over-the-counter diphenhydramine Benadryl almost every night.
Okay, so if you're a medical student listening to this, seeing that combination for a 66-year-old should set off some serious alarm bells.
Huge red flags. We have to immediately think about the Beers criteria.
The Beers criteria.
Yeah.
The master list of potentially inappropriate medications for older adults. Both of her drugs are right at the top of that list.
They are. Let's start with the Benadryl. Why is a simple OTC allergy pill so dangerous here?
I think a lot of people would be surprised by that.
Well, it comes down to the mechanism. Diphenhydramine blocks histamine, H1, to make you sleepy. But it's a dirty drug.
Yeah.
It's also a very potent anticholinergic.
Now, that's a word you hear all the time in geriatrics. Anticholinergic. Let's unpack that. What does that mean for Amy?
Acetylcholine is a key neurotransmitter for memory, learning, attention. Anticholinergic drugs block that signal. In a younger person, that might just mean a dry mouth. But in an older brain, which already has lower reserves of acetylcholine, these drugs can cause real confusion, urinary retention, just significant cognitive blunting.
And the long-term data is, well, it's pretty scary.
It's very scary. There are good studies showing that this anticholinergic burden is cumulative. The more you take over time, the higher your risk of developing dementia and Alzheimer's disease.
Wow. So she's taking a drug to feel rested, but she might be accelerating cognitive decline.
That's the tragic irony. And to make it even worse, tolerance to the sleepy effects of antihistamines develops in just a few days. So after a week, it's not even working anymore. She's getting all of the risk and none of the benefit.
So the Benadryl has to go.
Immediately. Okay, so that's out. Now let's look at the zolpidem. This is a BZRA, a benzodiazepine receptor agonist. How does this one work? Think of the brain as having a master volume dial. That dial is the GABA A receptor. GABA is the brain's main off switch, the main inhibitory neurotransmitter.
Okay.
Zolpidem hits that receptor and just turns the volume down on the entire central nervous system. It's global inhibition.
Which sounds like what you'd want, right? To turn everything down.
It works for sedation, yes.
Yeah.
But here's the problem in a 66-year-old. As we age, our liver and kidney functions slow down. Our metabolic clearance drops. So a dose of zolpidem that a 30-year-old's body clears out by morning might still be floating around in Amy's system at noon the next day.
Leaving her with that residual sedation, the hangover effect.
Exactly. And that leads directly to the #1 risk we try to prevent in geriatrics.
Falls.
Falls. A hip fracture for an older adult is a catastrophic, life-altering event. The mortality rate is shockingly high, and zolpidem significantly increases that risk because it impairs balance and motor control.
Not to mention the risks of delirium and those bizarre, complex sleep behaviors you hear about. Sleep driving.
Right. So for Amy, we have to get her off the zolpidem too, but we can't just stop that one cold turkey.
Because of rebound insomnia.
She'll have the worst insomnia of her life. We have to taper it down slowly.
Okay, so we've cleared the deck. We've identified the dangerous meds she's on. We're taking them away. Now we have to make the pharmacologic pivot. What do we replace them with?
This is where the science has gotten really interesting. We're moving away from just trying to sedate people, hammering the brain with GABA, and we're moving toward targeting very specific sleep and wakefulness pathways.
So let's start with option A, the DORAs, dual orexin receptor antagonists.
Yep, drugs like lemorexant or daridorexant. To understand these, you first have to understand orexin.
Okay, what is orexin?
Orexin is a neuropeptide. You can think of it as the brain's master wakefulness signal. It's the chemical that keeps the lights on. It stabilizes the awake state.
So if the old drugs, the benzos, are like slamming on the car's brakes to force it to stop.
And a door is just like taking your foot off the gas. It's a much more elegant mechanism. Benzos try to force sleep by suppressing the brain. Doras work by just blocking that stay awake signal. They turn off the switch, and that allows the body's natural sleep drive to take over.
That sounds much more physiological. Why is this a good fit for Amy?
2 big reasons. First, efficacy. The data shows DORAs work for both sleep onset, helping you fall asleep, and sleep maintenance, helping you stay asleep.
Which hits both of Amy's problems, the 2 hours to fall asleep and the 4:30 a.m.
Exactly, it covers all her bases. And second is the safety profile in older adults.
Which is key.
It's so much better. They don't cause respiratory depression like benzos can. And crucially, the risk of next-day impairment, the risk of falls, is significantly lower. It's not zero, we're still cautious, but it's a huge improvement over zolpidem.
So better efficacy, better safety. Is there a downside?
The main one is cost. These are newer branded drugs, so insurance coverage can be a hurdle. And some patients can still get some daytime sleepiness, so you always start with the lowest dose. But physiologically, for a patient like Amy, a DOR is the best fit.
Okay, so that's option A. What about option B? This one is really interesting, sort of teaching an old drug a new trick. I'm talking about low-dose doxepin.
Right. Doxepin is a tricyclic antidepressant, a TCA. And usually when you say tricyclic to a medical student, they kind of flinch.
Yeah, because they're known as being these dirty, toxic drugs with tons of side effects, especially anticholinergic ones.
Exactly. So why would we even consider it for a 66-year-old woman? Well, this is a perfect lesson in pharmacology in the concept that dose matters. At antidepressant doses, 100, 150 milligrams, doxepin is all of those bad things. But at very, very low doses, we're talking 3 or 6 milligrams, its binding profile completely changes.
Episode.
At 3 milligrams, it becomes incredibly selective. It basically only binds to the histamine H1 receptor. It ignores the cholinergic receptors, the adrenergic ones. It just hits histamine.
So it's acting like a pure, very clean antihistamine at that dose.
A super selective antihistamine without all the anticholinergic baggage we talked about with Benadryl. It's a really clever use of the drug.
So why isn't this the clear winner over the DORA? It sounds great.
It comes down to Amy's specific symptoms. Low-dose doxepin is fantastic for sleep maintenance. It's great at keeping people asleep through the night and preventing that early morning awakening.
Right.
But it's not very good for sleep onset. It won't really help her fall asleep at the beginning of the night.
I see. So it would fix her 4:30 a.m. problem, but she might still be lying there for 2 hours at 10:30 p.m.
That's the trade-off. It only solves the second half of her problem. So it's a strong runner-up and a great choice if cost is the main issue, since it's generic and cheap. But for Amy's specific pattern, it's an incomplete solution.
Can we briefly touch on 2 others that always come up? First, Ramelteon, the melatonin agonist.
Ramelion's safety profile is pristine. Basically, no fall risk, no dependence. For a very frail elderly patient, it's maybe the safest drug on the board.
But the efficacy?
It's weak. It's like bringing a water pistol to a firefight for someone like Amy. It just isn't strong enough for severe chronic insomnia.
And what about trazodone? I feel like everyone knows someone who's been prescribed trazodone for sleep.
It's the most common off-label prescription for sure. But for older adults, you have to be very careful. It's an alpha blocker, which means it can cause orthostatic hypotension.
Her blood pressure drops when she stands up.
Right. So imagine Amy gets up at 2 a.m. to go to the bathroom, her blood pressure bottoms out, and she falls and breaks her hip. It's a real risk, so we tend to avoid it when we have safer, more targeted options.
Okay. This has been a fantastic breakdown. We've analyzed the patient. We've gone through the safety data. We've weighed the mechanisms. Let's put it all together in the management plan. You're sitting with Amy. What's the plan?
The plan has 4 parts. First is deprescribing. We have a very frank conversation about the Benadryl. I explain why. For her brain health, that stops today. Then for the zolpidem, we start a slow taper schedule, maybe reducing the dose by 25% every couple of weeks.
Okay, that's part 1.
Part 2 is sleep hygiene reinforcement. We have to hit those perpetuating factors hard. The evening wine becomes herbal tea. The afternoon nap has to go. And we turn the alarm clock around so she can't watch it anymore.
Makes sense. And part 3, the new medication.
Given that she has problems with both onset and maintenance, a DORA like lemborexant is the strongest physiological fit. It targets her underlying hyperarousal, that wake signal, and it should help with both of her main symptoms.
And what if her insurance says no?
Then our plan B is the low-dose doxepin. We know it'll help her stay asleep, and we'll just have to rely more heavily on the behavioral changes to help her fall asleep. But the DORA is plan A.
This has been such a clear, comprehensive walkthrough. Before we wrap up this grand rounds, can we just synthesize the absolute key takeaways for the students listening?
Of course. 1, insomnia in the elderly is a safety-first game. Always, always check the Beers criteria.
Got it.
2, anticholinergics like diphenhydramine are basically cognitive poison for the aging brain. Just avoid them. And 3, The modern approach is all about receptor-specific targeting. DORs block the orexin-wake signal. Low-dose doxepin selectively blocks the histamine signal. These are precision tools, not the blunt force sledgehammers of the past.
That distinction, precision versus blunt force, it really feels like the whole future of the field.
I think it is, and that leads to my final thought for everyone to chew on. Ask yourself, what is the real difference between sedation and sleep? For decades, we just used drugs that knocked people unconscious, and we assumed that was the same thing as restorative sleep. It's not. With these newer agents, we aren't inducing a mini coma, we're just removing the barrier that's preventing the brain from initiating its own natural sleep process. We are facilitating nature, not overpowering it.
Facilitating nature. That is a really profound shift in thinking. And for our students on your next rotation, when you take that sleep history, look for the 3 Ps. Find that precipitating event. Find the perpetuating behaviors. That's where the real diagnosis lives.
Absolutely. Good luck out there on the wards.
Thanks for joining us on this deep dive. Go get some sleep. We'll see you next time.